we are going
Yes, sir. Yes, sir.
live in.
Ashok, sir. Yes.
Yeah, yeah. So I think it was a great fellowship, and especially like the last delegate said, the efforts from the faculty were immense. So every week the planning was there, the lectures were scheduled, and every faculty presentation was really, really great. Especially also the WhatsApp interactions. The questions, any question asked by a delegate was not left unanswered. So answer for everything was provided by the entire faculty list. And many thanks to entire faculty and especially Guru Reddy sir for agreeing for this fellowship. Thank you, entire Sunshine team. Thanks.
Thank you, sir.
So I think I'm able to be heard. You can hear
Yes,
me?
sir. Yes, sir. Yes, sir.
Great. So I think it's been a quite a satisfying experience even for us to get so many people under our wings and trying to help them as they start off their journey in arthroplasty. So most of our lectures were very basic because that's where mistakes are made. And we wanted you guys to really understand how to do a total knee and really get down to basics. We want to finish this lecture with a burning topic in total knee, which I think cannot be ignored. Any conference you go, interactions with surgeons, two terminologies you keep hearing a lot now. One is robotics, the other is personalized alignment strategies. And in a way, they are interconnected, and I'll show you why and how they are interconnected. That is number one. Second, there is a lot of confusion and mix-up of nomenclature, which I think I want to clear in this particular talk. Recently concluded ROC also. There were a lot of questions regarding alignment. I wish there was a whole session on alignment, but probably that's what we're doing in ISHK. I think we have a full 1 hour session on alignment with a lot of surgeons all over the world who are experts and who can speak on this. So this whole lecture will be structured in two ways. One is about personalized alignment, followed by robotics. So as I was beginning to put this talk together, I just wanted to check, is there anything new in knee alignment? And lo and behold, just a week ago, Bone and Joint Journal, just February 2nd, I think, came up with one of probably the most important articles of 23, which is the language of knee alignment. So the confusion that I see and which is echoed among us as surgeons is also there across the globe. So very reputed people like McDessie, Haddad, Mark Pagnano, Jan Victor, they all came up with this article about language in knee alignment. And they're talking about two very important things. One is what is alignment and what is soft tissue balance. And they, in their summary, say these two are the most crucial factors which are surgeon driven. If we can improve patient satisfaction. And I think it's also, on the side note, a matter of pride for the Sunshine team, because our work on coronal plane alignment classification was cited in this particular paper. Our experience in robotics is a little over 3 years. And in personalized alignment is probably for the last 2 years. So we as a team headed by Dr. Reddy have been very conscious of all the new developments, and we wanted to see whether these are applicable to the Indian population. And then as a part of that series, this paper was written. So how will this talk be structured? First, we will deal with what mechanical alignment is, what is its current status, what are the advantages, and what are the disadvantages. And keeping these disadvantages in mind, how was personalized alignment strategy conceived? What is the fundamental basis of personalized alignment? We will discuss the concept of constitutional varus. That's from where it all began. And where are we right now, which is the CPAC classification. Even in a lot of conferences, you hear very senior authors talking about 15 alignment strategies, 17 alignment strategies. But I think the core fundamentals can be divided into three, which is kinematic alignment, restricted kinematic alignment, and functional alignment. So we will discuss these three alignment philosophies and what's the rationale behind these three alignments. And then we'll end up with how does robotics fit into all this. So to start with mechanical alignment, this has held us for nearly 4 decades. All credit to Dr. Insol and Dr. Ranawat that they came up with mechanical alignment. And please understand, you're talking about 1970s, where survivorship was the key. People would see catastrophic failure in 1 year, 2 years. So then surgeons and stalwarts like Insol and Ranawat had to come up with a strategy where the implant had to survive. So nothing else was more important than survivorship. So here in mechanical alignment, you have to understand that you have the same goal for every single patient. Every single patient, irrespective of how much ever variation they have, the target was same. So here we cut the tibia and femur at 90 degrees to the mechanical axis. That is what we've taught you for the last 7 or 8 lectures. And once you do that, you end up putting everybody in neutral alignment and neutral joint line obliquity, because that is the reason why you will have equal compartment loads and thus preventing failure and survivorship. So this concept has done extremely well, and you can see in terms of survivorship 92 to 94% in 15 years, and at 25 years 82% survivorship. So even today, I very cautiously submit to you that mechanical alignment is still the gold standard and should be what we all surgeons should aspire to learn before venturing into personalized alignment strategies. So slowly, when we started having very good survivorship, we started realizing this concept of looks good, feels bad, meaning you as a surgeon, after you do a surgery, a patient comes up for your follow-up and you can see an X-ray like this and you're very proud as a surgeon, but the same sentiment is not echoed by the patient. Patient still has some niggling pain, he's still complaining, doctor, I still don't feel right, I have some pain in my lateral side, I don't feel my knees very natural. So all these things started coming up. Because we achieved survivorship, our goals slowly started shifting. This whole thing started happening around 2000 to 2010. And then author after author came up with dissatisfaction rates after total knee, which are very different from total hip, which has a much better satisfaction level. And if you ask me, in my personal practice over the past 6 to 7 years, I do perceive and see that a lot of my patients are also unhappy. Reasons can be many. For example, this is a systemic review done in 2017. You can see patient dissatisfaction is multifactorial. It is dependent on social aspects, demographic, ethnicity, weight, mental health. But what is key for us is the surgeon-related factors, which you can control as a surgeon, which is based on the technique, the implant you use, the laxity pattern you leave the knee in, and what component alignment you want to put these patients in. And second is post-operative. You have to make sure patients don't have stiffness, good pain control, good function, so that your patients are much more satisfied. So we are all doing mechanical alignment, but still we don't have satisfaction, right? So is there a problem with mechanical alignment? So this slide tries to address that. So in the beginning, I said everybody gets the same target. So systematically in mechanical alignment, are we changing something? The answer is absolute yes. So here you can see, let me put this slide back again. So here you can see that in a knee which is oblique, meaning you have valgus in your femur and varus in your tibia, when you cut it at 90 degrees to the mechanical axis of the femur and tibia, you are distalizing the lateral aspect, So this is where the cut should be, where the femur ends, but you are cutting almost here so that it's at 90 degrees. At the same time, instead of cutting at varus, you're cutting at neutral. So your lateral column is lengthened and your medial column is tightened because you're cutting at 90 degrees. So what does this do to the knee? It creates medial tightness. This was initially perceived as ligament contracture, and you end up releasing in almost every single patient. In extension, you have to do posteromedial release, and in flexion, you externally rotate so that you can make space. So in every patient, you're changing the joint line obliquity as well as changing the native alignment of these patients. And now it's been perceived that this is what's causing change in anatomy, change in ligament laxity, and change in kinematics of every single patient. So then surgeons started trying to understand, are we doing our knees wrong? Should we do something else? Okay. Now here comes the conflict. Now, why did we all do this? We did this for survivorship. On the left side of your screen, you see probably two of the most important articles about where the tibia should be. One is by Merrill Ritter, the other is by Michael Beren. And both of them have said, if you go beyond 3 degrees of varus in your tibia will start collapsing. You'll have medial collapse and you have failure. But on the other side, you can see two articles by Danbury's group from Mayo Clinic, who are exactly saying the opposite. Again, landmark papers by them, 15 years survivorship and 20 years survivorship of almost 400 patients. They divided them into an aligned group and an outlier group. Aligned group had overall varus less than 3 degrees, and outlier group had more than 3 degrees of varus. And they've very clearly shown that there is no difference in survivorship at 15 years and at 20 years. So why are these knees failing on the left, and why are these knees failing are surviving on the right? So that's the big question, right? To give some credit to Merrill Ritter, he did this study in 1975 to 83, where the implants, the quality of the plastic that we were using, the instrumentation that we had was very crude. Okay, so maybe that led to failure. But clearly now, my perception between these two papers is a malaligned and an ill-balanced knee is very different from a natively aligned knee, which is well-balanced. So when a surgeon gets very jittery to put 2 or 3 degrees of varus to recreate the native alignment, it is very different from giving 2 to 3 degrees of varus in a patient who doesn't need that, and you don't balance your knee well, because of which you will load one side or the other, lead to failure. So this is a very key slide for you to understand that when you are achieving native alignment, you are putting the patients in their own alignment, which is natural to them. And at the same time, you have to balance these knees. This is very different from an imbalanced knee and a malaligned knee, which can cause failure. So that's the first distinction that you should make. Now that we know all patients are not same, for example, this is a group of rugby players. Every knee is different. They are all in their teens. They are all very physically fit. And you can see the blue guys are in valgus, the green guys are in neutral, and the yellow guys are in varus. So if I put all these knees in neutral, will they feel the same perception? They might not. So that's how people started thinking that, yes, everybody is different, but can we quantify it? Can we classify it? That was the next challenge. If you want to move away from mechanical alignment, what is your goal? So the first paper, again, a very important paper from Johann Bellemans. What did they do? They took all young pre-arthritic patients in their 20s to 27 years of age, Caucasian population, and they started measuring what is the normal varus in each of these patients. And they came up with some very important findings. So they very clearly showed this is not arthritic knee. This is a normal pre-arthritic knee. 2/3 of their patients in men and 17% of women had more than 3 degrees of natural varus. If you are ignoring this and putting everybody in neutral, are you creating a problem? That was the question. So their average LDFA, which is lateral distal femoral angle, was around 88 degrees, which is 2 degrees of valgus. And the MPTA was 87, which is 3 degrees of varus. And they've also said, and this is backed by other studies, only 5% of our population has a neutral mechanical axis, meaning if you take 100 patients, only 5 of them need a mechanical neutral axis as their target. So this paper really blew up. It got a big award and people started working out, okay, now you know that every patient has some amount of varus. The next challenge was, can we classify, can we quantify, can we put them into compartments and groups? This paper, I think, came out in 2008, 2010, and it took a long time for people to figure out how to do this. And the most successful of all these classifications is the CPAC classification given by McDessie. Again, this has really caught on fire. We follow it. So do many surgeons who follow personalized alignment strategy. So what did he say? He said two things. You can classify the patients based on HKA, which is hip, knee, ankle, and joint line obliquity. Based on these two numbers, you can classify patients into 9 phenotypes. So when you talk about personalized alignment, surgeons say, what is my target? This is your target, okay? For every single patient, you have to get a scanogram. You have to calculate the arithmetic HKA and joint line obliquity of every single patient. Once you do that, you will understand where to classify these patients. So you will know whether they are in varus, neutral, or valgus. And you will also know whether the joint line is apex distal, neutral, or apex proximal. So this combination will give you 9 phenotypes. If you can do the surgery, put the patient back in his native phenotype, you might have better patient-reported outcomes. So that is the whole hypothesis. And this has variation based on ethnicity as well as age. So when we read this paper, it was very evident that what Caucasian population has is very different from Japanese or from US. So we went ahead and we did the same study in our population. I'll show you the results. So how is arithmetic HKA calculated? MPTA minus LDFA is arithmetic HKA. If you have it less than 2, it is a varus knee. Plus minus 2 is a neutral. Anything more than 2 is a valgus knee. So there is another small distinction that I want to make. Arithmetic HKA is different from mechanical HKA. Mechanical HKA is nothing but mechanical axis of the tibia and the femur and the angle made by that. And we know as the deformity increases, mechanical HKA changes because the joint line congruency angle keeps increasing. Lateral opens up, medial tight. So mechanical HKA changes, but the LDFA MPTA don't change. So if you want to know what is the native alignment of that patient, instead of using mechanical HKA, you have to minus MPTA minus LDFA, which gives arithmetic HKA. So any joint line subluxation or change in the joint congruency is negated by calculating the arithmetic HKA. So that is about arithmetic HKA. Then moving on to joint line obliquity. MPTA plus LDFA, which is 180, which is neutral, less than 177 is apex distal. Apex distal meaning the lines meet distally. Neutral, which is they meet in the center. Apex proximal means they meet on top. So these are the numbers. So every single patient, now we calculate arithmetic HKA and joint line obliquity, and we classify them. So this is the data from McDessie, where he's clearly shown in Caucasian population, type 2 is the most common, followed by type 1. We are talking about arthritic knees now, followed by type 5, which is actually the neutral, where you have neutral mechanical axis and a neutral joint line. And compare this to our results of 1,000 patients, where we did it in 500 non-arthritic patients and 500 arthritic patients. You can very clearly see we have more CPAC 1, which is more constitutional varus with an apex distal joint line. Our second highest is again constitutional varus with a neutral joint line. And third is neutral with apex distal joint line. So we had more 1, 4 as well as 2. Okay. So now we understood what is the native phenotype in our patients. So CPAC classification is the fundamental basis of personalized alignment. Now let's go on to what are the various different types of alignment. So till now we've discussed what is mechanical alignment, What is the problem with mechanical alignment? What is the fundamental basis on which personalized alignment strategy is being created? It is based on the phenotype. So once you know the phenotype of a patient, you have to use one of these alignment strategies and do the surgery. Okay. So we've already discussed mechanical. We will start off with kinematic alignment, then move on to restricted kinematic, and then move on to functional, which probably are the most important. And I'll tell you why with reference to Indian patients. So this is the first attempt to classify personalized alignment. This is by Charles Revere. This is where all the confusion started because of the nomenclature. So alignment is almost, how should I put it? It's like spinopelvic relationship in hip. People start reading it. It gets confusing because of the terminology and people stop. So same thing started happening to alignment strategies. So if you look at Charles Revere's work, it makes sense, but it's very difficult to understand. So he classified them into systematic, patient-specific, and hybrid. Systematic means same target for everybody. That's where you have mechanical alignment and anatomic alignment. Patient-specific is like a unicondylar or a pure kinematic where you're recreating the absolute native phenotype. But is there a middle ground? Yes, there is a hybrid strategy where you can do adjusted mechanical or restricted kinematic alignment. So this is what we keep hearing in conferences and our mind shuts off. We don't understand what they're talking about and then we don't read about it. So this paper, Language of Knee Alignment, which I told you, we just came out recently, came up with a different nomenclature, which I think makes more sense. They said either it is fixed or it's individualized. Very clear distinction. Fixed means same target for everybody, either mechanical or anatomic. We won't discuss anatomic because it just has historical value, but cheers to Krakow because he came up with this, but they couldn't do it because of the instrumentation that was available then. The second half is individualized alignment where you have kinematic, restricted kinematic, and functional. The other ones I would not discuss here because it just starts getting a little more complicated. So probably this is the most important slide. If you have to go away with something in your mind, this is what you have to go away with. Now, how are all these alignment strategies different? So that is where all the confusion is. So it's very clearly laid out here by Venditoli. Here you can see you have alignment and you have soft tissue balance. Based on these two criteria, all these alignment strategies vary. Okay. To start off with kinematic alignment, it's an unrestricted strategy, meaning whatever alignment comes, they take it, meaning 8 degrees of varus, 7 degrees of valgus, they would just go ahead and cut it. Number one. Number two, they accept whatever native alignment you get at the end of surgery, meaning if you have lateral laxity, they accept. If you have medial tightness, they accept. They don't touch soft tissues. And they usually do it with femur first. So K, remember, it is unrestricted, meaning there is absolutely no boundary where you will leave your femur and tibia and you accept native alignment. Restricted kinematic is a more conservative approach. So this came up with they came up with the idea saying, this looks too bizarre. I can't put my knees in so much of varus or valgus. I don't know what will happen to them in the future. So Venditoli described some boundaries. I said, okay, I can't put them in such a wide spectrum. So I can do it in a safe boundary. So I will tell you what those boundaries are, but still they accept native laxity, meaning at the end of surgery, whatever laxity they get, they accept it. So the difference between kinematic and restricted kinematic is the boundaries that are set in restricted kinematic. So that's what the even nomenclature says. Now let's go to functional alignment. Okay, we will for now ignore inverse kinematic. In functional alignment, apart from restricted boundaries, which are defined in a different way, you are also saying my balance is also equally important for me. I won't leave my knees too lax or too tight, So kinematic alignment is unrestricted with native laxity. Restricted kinematic is restricted boundaries with native laxity. Functional alignment is both restricted as well as balanced. This is a strategy where balance has little more value than the alignment. So I will describe them. Any confusion here? people have understood this? Because this is the most important part. Okay, let's move.
Sir.
Okay, so now let's go to kinematic alignment. I think big credit to Stephen Howell. He came up with this in 2008. People almost thought he was crazy. He was a fool. And 13 years now, he's probably the most talked after, receiving honorary arthroplasty memberships, awards everywhere, because he's the first one who moved away from mechanical alignment and said, no, this is not the way to do. There's another way of doing a knee. And he came up with the concept of kinematic alignment, which I said is unrestricted and you respect native laxity. So what is the fundamental basis of kinematic alignment? There are 3 axes in the femur. Okay, one is the flexion extension axis, where the tibia flexes on the femur. So that's your flexion extension axis. The second axis is the patella flexing and extending in the trochlear groove. The third axis is internal external rotation of the tibia on the femur, which is usually on the medial side. These 3 axes were individually described by biomedical engineers and surgeons. And what they finally realized is these 3 axes, they are either perpendicular or parallel to each other. And more importantly, they are parallel or perpendicular to the joint line. So Stephen Howell came up with the concept that if I cut my tibia and femur parallel to my joint line, I would recreate this cylindrical axis of the femur, thereby creating kinematic alignment. I've read this thousands of times. It took me years to understand. So finally, this is the whole gist. So the whole idea is to recreate the cylindrical axis of the femur on which the tibia flexes and extends, on which the patella flexes and extends, on which the tibia rotates over the femur, which is the medial pivot and lateral rollback. Okay. So how is this done? If you recreate this, so recreating the femoral anatomy is the most important here. If you want to do some recut, you can only do on the tibia. And it is also important for you to understand there are special instrumentations required, as well as a special implant, which is a medial pivot implant. And the lateral femoral flange in these knees are also reduced. So this was developed in UC Davis by Stephen Howell and Professor Davis. So this was described when there was no robotics. So remember, kinematic alignment was a caliper-based technique. So for 10 years, he developed this technique, heavily published, and you can read about it. So here is the result of the surgery. So what are you doing? You're cutting it parallel to your LDFA, parallel to your MPTA, parallel to posterior condylar axis. A lot of surgeons have problem in this because you internally rotate your femur to do this cut. You, whatever soft tissue laxity you get, you accept. But credit to him, now he has 13 years data, and you also have registry data from other surgeons who practice kinematic alignment. There is no difference in the survivorship of these knees compared to mechanical alignment. That is very well established. So that is almost after 10 years, because these knees survived, people started accepting maybe there is some benefit to this, and surgeons all over the world started accepting kinematic alignment. But what are the problems here? You can get into imbalance because of the way you're cutting. You have to internally rotate your femur. You have to put your femur in various degrees of alignments, which sometimes is acceptable or not. The other problem is combined varus and slope. So he says give native slope as well as native varus. We know that is also a reason for failure. So conservative surgeons and probably 90% surgeons around the world, they were too conservative to even venture into this. So this is just an animation of how this is done. You account for wear, then you cut equal amount of bone from the distal aspect of the femur, and then again you cut equal amount of bone. Equal amount of bone is nothing but the thickness of the implant, so that you can recreate the joint line. And then you do your chamfers. How much you cut? That's again a very common question asked. I'll show you how much to cut. you have to account for 2 millimeters of cartilage, and you have to account for 1 millimeter for the curve of the blade. So usually you're cutting around 6.5 to 7 millimeters of bone in order to put an implant that is 9 millimeters, because cartilage is already worn out. So that is how we came up with the caliber based measurement. Similarly, on the tibia, if you have wear, compensate for that wear, and usually you cut around 7 mm. And once you cut, you also, so this is where you give varus and slope, and surgeons had a big problem with this. They would say that this will lead to failure. Especially in Indian knees, we have so much more slope than them. So none of the Indian surgeons probably would ever dare to do this even today. So this is the concept and how the video of kinematic alignment looks. So now if you are so scared of kinematic alignment, then Venditoli came up with the concept is, why don't you define some boundaries which are safe, in the sense that within that boundaries, maybe my implants will last, based on the data from Mayo Clinic, where they said, even if you're within or without, even within 3 degrees, the implant will definitely survive. So that is what was in his mind. So to mitigate the risk of outliers, Venditoli came up with the concept of restricted kinematic. So from unrestricted, we are moving to restricted, but still native laxity is important for us. So what did he say? He said, instead of putting the femur and tibia in so much of varus or valgus, let us define a boundary of 5 degrees. Meaning, on the femur, I'll go up to 5 degrees of valgus, and on my tibia, I'll go up to 5 degrees of varus. So 5 degrees of valgus and 5 degrees of varus. And the second criteria, he said, once I do this, my HKA axis has to be 3 degrees. If it is more than 3, I will again start moving my implant till my HKA axis comes to 3 degrees. You again respect native soft tissue, but there is more chance that maybe some cases might go out of joint line obliquity, but most of my cases will fall under joint line obliquity. So this is a very complicated algorithm, but just understand that if your MPT and LDFA is less than 5 and HKA is less than 3, you don't have to do anything in your surgery. You just go ahead and do your surgery. But if one of them is off, the first thing you do is bring your implant down to 5 degrees. Once you do that, check if your HKA is more than 3 or less than 3. If it is more than 3, again, femur is important. So you don't change anything on the femur. You try to change your varus in your tibia so that the HKA axis comes down to 3 degrees. So the only 2 things that you have to remember here is my individual alignment has to be less than 5 degrees and my overall HKA axis has to be less than 3 degrees. So the whole fundamental basis of restricted kinematic alignment is that. Then came the concept of functional alignment. Functional alignment is again slightly different. And as I said, this is a balance-driven strategy, meaning I will balance my knee and I will accept whatever alignment I get at the end of my balancing. Okay, that's the whole concept. It was given by Faris Haddad and Mark Pagnano. So to call something functional alignment, you need 3 things. One, it has to have a 3D plan, number 1. Number 2, it has to be robotic assisted. Number 3, it has to be a balance-driven strategy. So what happens in this? Here, you're trying to put the implant within, again, boundaries so that you just don't touch soft tissues. Okay. Once you do that, you don't have to do any releases, number 1. Number 2, how do you do this? First, you capture your gaps. I'll show you how that is done. Then you change the position of the implant on the robotic software so that your gaps are balanced. At the end of balancing, whatever alignment I get, I accept that. Okay. And I have put restriction on how much I can move my implant also. Okay. So in a nutshell, functional alignment allows you 5 degrees of HKA. Okay. So it is little more aggressive as compared to restricted kinematic, where we said it is 3 degrees. Functional alignment says, in the interest of balance, I will give little more. So for you in coronal plane, functional alignment allows 5 degrees, meaning I can put 3 degrees of varus in my tibia, maybe 2 degrees of varus in my femur. So overall HK axis is 5, and I'm doing that in the interest of balancing the knee. So they are giving equal importance to alignment as well as balance. Okay, so these are the 3 alignment strategies. So I've just discussed the basics. Kinematic is unrestricted native laxity. Restricted kinematic is restricted boundaries with native laxity. Functional alignment is balance driven, where you want to balance the knee. At the same time, if you can keep the patient in native alignment, you accept that. Even if you have to move him out of the native alignment, you do that in the interest of balancing the knee. Okay. Now, where does robot come here? Okay. These, I just put this so that people have the knowledge of what are the different robots available and what differentiates them. Okay. Starting with Mako, which is Stryker, Navio, which is Smith & Nephew, which is discontinued now. Rosa is Zimmer. Hori is the new iteration of Navio, so that's Smith & Nephew. Cuis is from Merrill, and Velis is from Johnson & Johnson, which is the latest one that is available. First area of differentiation is whether it is image-based or image-less. Okay, there are only 2 image-based systems. One is Mako and one is Cuis. Both use a CT scan. The benefit is you can do excellent preoperative planning in these 2 because you already have a bone model. You can superimpose your implants, you can change them, you can see how best you can fit the femur and tibia. But the other ones don't have a CT-based planning. So what happens, they have to rely on bone mapping or cartilage mapping, which happens intraoperative, where some amount of error can be there. So the first differentiation is image-based versus image-less. Image-less doesn't have the disadvantage of CT radiation cost. Image-based, though these are the disadvantages, you can definitely have a preoperative plan. But because you're doing this cartilage mapping, you're picking all your points, there can be some amount of error. So if Mako and Cuis are image-based, where are they different? They are different fundamentally in the way the robot functions. Okay, Mako is a semi-active robotic system, whereas Cuis is an automated robot with a burr. Mako can use a saw, you can use a burr, and you can use a reamer, and you can do total knee, partial knee, as well as total hip. But as of now, Cuis, which is based on the Robodoc Curexo system, has a burr and it can only do a total knee. And I think they've recently launched uni. So that's where the difference between Mako and Cuis. One is automated, one is semi-active. The other ones are Cori, Velis, as well as Rosa. Rosa, I think, is the least evolved because all that it does is it has a robotic arm, but it can only put the jig where you want it to, and all the cuts are done manually. It is less favored all over the world. Even in India, I think very few centers have Rosa. So that leaves you with Cori as well as Velis, which are, again, they are image-less systems. And Velis has a robotic attachment, while Cori is a burr-based system. Of all this, we personally have maximum exposure to Mako, which I think is the most advanced because 1, it is CT-based, so you have very good planning. 2, it's versatile because you can use a saw, a reamer, or a burr, and you can do all the 3 surgeries. And you can also do a lateral uni, medial uni, bicompartmental, everything. Okay, so that's what we are using. So if you look at the robotic workflow, it's very simple. You have a CT scan, then you pre-plan it. This part of the surgery is same for everybody in all systems, where you have to put the arrays, register the bone, and then you do intraoperative balancing. Once the balancing is done, you take the cuts, you do your trials, and you're done with your surgery. In Mako, you have these 3 features. First is enhanced planning. So you can see here, you can plan the sizes right from the tibia as well as the femur. Femur plan is 3-dimensional, meaning I can look at the mediolateral fit, I can look at the trochlea, then I can even look at the posterior condylar offset, whether I'm recreating that. So you can see here, I'm able to do that. I know what osteophytes are there. I know what slope to give, and I know the combined flexion parameters. So that's how well informed you will be even before the surgery. Once this is done, the second feature is dynamic balancing, and you can clearly see here, these are the initial gap numbers. And now here I'm moving my implant so that all these numbers come to 18, which is equal to a 9 mm poly thickness. So I'm giving 1 varus in my femur, and then I'll give 3 varus in my tibia. I distalize my implant, and then I flex the knee. My medial is tight, so I'm giving rotation. As I rotate, my numbers all become 18. So even without touching soft tissue, I've maneuvered my implant. I've changed everything. In the end, I've given 3 degrees of external rotation, 3 degrees of varus, and 1 degree of varus in my femur. And I'm accepting 4 degrees of varus in my overall alignment. Okay. And then once this is done, the cuts are very simple. It is robotic assisted. The second big advantage of Mako is this haptic. So when you do these cuts, you're within the haptic. Soft tissues are very well protected. So there are 6 cuts that you make. The chamfer is done. The posterior is done. Then you move on to the tibia. And once you do the tibia, you move on to the distal femur as well as the posterior chamfer. So very accurate system, sub-millimeter accuracy. So what are the advantages of Mako that we perceive? It's the only system where you can do enhanced planning. It achieves any alignment strategy you want. It is haptic guided. It protects soft tissue. It's based on a system, the implant that is used at Triathlon, which is again one of the best systems. 10-year Mako data is available. I think all the other systems are just very new. So slowly they're coming up, and it's very versatile. And we've done over 4,000 procedures at Sunshine using the Mako system. So I'll just show you one case example to show how we are personalizing alignment in our patients. So this is a patient that my patient I did a few days ago. We take a CT scan, we take a scanogram, we calculate the MHK, LDFA, MPTA, AHK, JLO in every single patient. So I've described and told you what these are. So at the end, we get a CPAC classification of type 1. So I know where my knee is. On the left side, again, I'm CPAC 1 and I know my numbers. So here, we did a feasibility study. So after we did the CPAC classification, we wanted to see which alignment strategy works in our patients. And we ended up realizing that restricted kinematic and functional are the only 2 systems that we can use in our patients. So this is a result of the study that we did. 110 patients, we tried to do all alignment strategies, kinematic, followed by restricted kinematic, followed by functional. 36 of our patients, that is 30% of patients fell into restricted kinematic alignment. 54 patients percent fell into functional, and 14% of 14 knees didn't balance irrespective of the alignment strategy we used. We had to further do soft tissue releases. Second takeaway was, if your knee stays in restricted kinematic alignment, you don't change CPAC phenotype, meaning it is more amenable to give you that CPAC. That's what we discussed, right? Restricted tries to recreate the joint line obliquity of your patient. Whereas functional alignment, because our deformities are so much worse, 93% of patients who went into functional alignment, we had to change the phenotype. We had to give more varus, close the lateral gap. We had to give more varus on the medial side. So if you do functional alignment, there are good chances that you are changing the CPAC of that particular patient. So based on this result, we said, why don't we start a RCT where CPAC 1 bilateral patients with equal deformity. Let us do restricted kinematic on one side and functional alignment on one side. We'll see how many fall in the same CPAC, how many in how many functional we change CPAC. And at the end of 1 or 2 years, we know which knee is doing better. So this is a study we just started. So this is one of our patients. On the left side, this is a normal plan. Then I move on to restricted, move on to pure kinematic, where you do 7 cut on the distal, on the tibia, 6.5 distal femur, 6.5 posterior. Now you can see that this is too much of varus. So we decided that that's too much. So we move on to, from pure kinematic, we move on to restricted kinematic, where the first thing to do it is bring your implant within 5 degrees. So valgus, you don't have to worry because it's already less than 5. And I brought my varus from 6.5 to 5. That's the first thing. Now the second thing I look at is 5 minus 1, which is 4. So my HKA is 4. So it is still out of boundary. So the next thing I do is I further reduce my varus to 4. So now my knee has 1 degree of valgus 4 degrees of varus, which is a HKA axis of 3. So I moved from pure kinematic to restricted, and within restricted, I moved to a HKA axis of less than 3 degrees. So this is how you plan for a restricted kinematic alignment. So we moved on, and then we balanced this knee, and you can see the initial gap captures 1923, 1720. We moved on to, so here we are not doing any coronal manipulation. Can you see? We just raised the tibia 1, moved the femur down, gave 3 degrees of external rotation, and you end up with 1719, 1919. So one risk with restricted kinematic, you might remain unbalanced, okay, where you have to do soft tissue releases. And you know, functional alignment prevents soft tissue releases. So that's where the difference is. So here I did this, I raised my tibia by 1, did little more release, and the head of surgery, I got all 18s, which is a 9 mm poly. Now let's see what I did on the right side, where my plan is functional alignment. So I start with a basic plan, which is a mechanical alignment plan. Then I move on to capturing the gaps. So gaps were 22, 20, 23, 18. I move on to dynamic balancing, where you can see by moving the tibia up by 1, moving the femur down by 1. So here I'm conscious of my alignment, but I'm letting balance drive it, right? So I'm moving the implants. Then I gave 2 degrees of varus in my tibia. Then I flexed it, gave 4 degrees of external rotation. And then finally 1 degree of valgus in my femur. And as I do it, you can see that I've balanced this knee. But the end, see what I did. I gave 1 degree of varus on top, or valgus on top, and 2 degrees of varus. So still I could keep the native alignment in this patient. If I could not, I would have moved him out of alignment. So that's the whole idea. At the end of surgery, again, I have achieved 18s, both in flexion extension, but my implant position is very different from what I did in restricted kinematic alignment. So here you can see at the end of surgery, on the right side, I did FA, but I still maintained CPAC phenotype. On the left, I did restricted kinematic. I still maintained CPAC phenotype. Okay. So this is how personalized alignment strategy is achieved. So take home message, very simple. Mechanical alignment is still the gold standard. All you guys are just starting with your careers, doing your initial cases. This is what you should aim at. Get consistent results with least number of complications. Once you understand and know how to do a very good total knee, then venture into the space of alternate alignments, robotics. Because in robotics, the brain is still the surgeon. The robot can only achieve what you want it to achieve. So please stick with mechanical alignment for now. But do understand, if you do mechanical alignment, you're systematically changing the anatomy of every single knee. The dissatisfaction because of surgeon-related factors could be because of this, because of which personal alignment strategy was developed, which is based on native alignment, joint laxity, as well as soft tissue laxity. A lot of research is going on what soft tissue laxity is good. Once you give a native alignment, and a good balanced knee is very different from a mal-aligned, ill-balanced knee. The hope of personalized alignment is better patient satisfaction. And then the 3 alignments that we discussed, pure kinematic is unrestricted native laxity, restricted kinematic is restricted native laxity, functional alignment is a balance-driven strategy, which is also restricted in a way. Our feasibility study has shown we do more FA than RKA in order to balance. So that's the reason we are doing a trial on CPAC once to see which alignment strategy will do better. Personalized alignment will need the aid of technology. You cannot do all this without technology. Robotics is here to stay. If your goal is mechanical alignment, you don't need a robot. That is where you should start off. There are too many robots available, so it is important that you gain knowledge, and if and when you want to choose, you have to choose wisely. So that's the end of my talk. And I think we are open to questions now.
Yeah, wonderful talk, Suhas. Very well done. Can you hear me?
Yes, sir.
Yeah, I'm sure you have succeeded in confusing all the youngsters. This is a much advanced talk for them. So,
Yes,
but anyway, they have to know. They have to know.
But
Yeah.
in spite of being much advanced, actually, he's made it very clear. So I
Yeah,
think
very
that's
well
really,
made. Very well
really
made.
well done, sir. Superb.
You got an excellent teacher in you, my friend.
sir.
I think your church experience has helped you, I think.
Yeah, I
You
think even for us, when we started off into this, it took a long time for us to understand. As and when we tried to interact with all the foreign faculty, interactions with them, then we slowly started developing this. But it is very clear, sir, if you want to put everybody in mechanical alignment, those knees will definitely survive. But the surgeon-driven factors for dissatisfaction are definitely there. So a lot of studies are going on between mechanical alignment on all these alternate alignment strategies. And definitely the personalized ones are doing better at 2 years of outcome. And all the hype about failure, I think I try to clear that a well-balanced knee in native alignment will survive. And there is enough data showing that.
wonderful. You said your class is like a sermon. Sermon itself. Okay, guys, fellows, at least ask one question so that we know that you have not slept.
If you don't ask, I'll start asking.
What everyone should do, even our fellows, is really keep this talk aside for a later date when you get into the actual arthroplasty and you'll start having those questions. You will come back and realize that, okay, all were answered in this talk because it was so beautifully told. It's like a story you just laid out, sir, for everyone.
Yeah, so we started off why mechanical works and why it's not working, and what's the basis of personalized alignment and where we are as of now. And I think it's all because of Sir that he's given us the liberty to, move out. If Sir was very rigid about, no, I want mechanical alignment in each and every patient of mine, none of this could have been achieved. So hats off to Sir for his open mind.
Yeah.
It's up to you, my friend. You added such a value to this. Really, it's very wonderful. So the McDessie and Haddad quoted our paper?
Yes, sir.
Wow. Recently came?
It came just 5 days ago, sir.
Oh, boy.
Yeah.
Because when I was in Mali, you said that it was quoted in some other paper.
Yeah. So actually, when you were in APAS, that's when we just reached out to him on LinkedIn. He was very interested what our results were. So Prasha, I don't know whether he's online, but he authored the whole paper. So we sent our results to him. He was really intrigued to see the difference in what our patient pathology is versus theirs. So that's how it came into light. And then he started quoting it. Vigdorchik has quoted that paper. So it's getting good traction. For us to know what to do, we needed to know where our patients are. So that's how we did the CPAC first. Then we tried all alignment strategies. And now we have a good idea which ones work. So now we're testing RKA versus FA in our patients. So it will be really interesting to know.
I think the previous IACon, when McDessie was giving the talk, he put a slide of the article and now it's been quoted.
Yes, exactly. Yeah.
Our article.
Even when we went to ISOC, I think they had quoted this paper.
Yeah, exactly.
Yeah.
There's some questions in the chat box, I think. Ratnakar, can you just...
There is a question, is native locking and unlocking of knee possible with implants? Native locking and unlocking of knee possible with implants?
So it is, of course, when you straighten your knee, and because of the rotation of the femur, the screw home mechanism happens and the knee gets locked. And that is very important for us. If your knee is flexed, the quadriceps keeps firing to maintain that flexion. And the patients will not be very happy. So only when your knee straightens up and the screw home mechanism happens, the quadriceps relaxes. So all these knees are designed to do that. The other aspect is the medial pivot and lateral rollback. So studies on pressure sensing have very clearly shown in kinematic alignment and in all the other alignments that does happen. That's why in kinematic alignment, they move to a medial pivot knee where your medial is very stable and the rollback happens on the lateral side.
Anything about difference in implant, which was told in earlier part of the discussion about the medial pivot, something like that?
So this is again a
Oliver.
big topic of discussion. Why are surgeons more comfortable doing these alignment strategies is because of the amount of engineering that has happened and the quality of implant and plastic that we have. So as of now, because these are the only knees that are available, we're using them with alternate alignment strategies. But by and large, if you see last 2 decades of research, in terms of functional outcome, no implant has been superior compared to the other. So if you see the Venditoli classification, the first one is implant design that I didn't discuss. But in terms of functional outcome, I think all implants do the same. Everybody has their preferences and choices, both with advantages as well as disadvantages. So I think you can try alternate alignments or this with every implant. But kinematic alignment works very well with a medial pivot design, which is designed by Medacta.
The same thing, so as the medial pivot of the right.
It's slightly different, sir, because they've also discussed, so when you internally rotate, there's a problem with tracking also. So they have changed the lateral flange angles of the femur so that the tracking is better. So if you, in other words, if you try to do KA with a normal knee, it might not work as well. That's why they came up with a new implant.
But according to you now, the functional alignment is the best?
So there's this, that's the conflict we have, sir. Definitely personalized alignment is the way to go in terms of target. In that's the reason we're doing that study. Should we stick to alignment and accept some amount of laxity versus keep balance as your focus and accept little malalignment, which one will do better? So that's why we're doing that study. And I feel RK will do better. Intuitively speaking, if you have some, because every knee has some amount of natural laxity, right? You should accept that. So that's the reason now we are accepting 1 to 2 mm of laxity in extension and maybe 2 to 3 in flexion on the lateral side. But your medial has to be solid. There's no doubt about that.
Just one question, Dr. Suhas, from my side. Actually, comment come question. Actually, after my retirement, actually, I had exposure to 12 different companies of joints, 12 joints. Of course, I learned 5 or 6. Question is, after hearing such a nice lecture from you, describing all types of alignments and different designs, do you suggest any design in the implant which will suit to your thing? See, finally, what you are doing is, we are making either cuts or soft tissue balance, getting that particular robot to do it. Rather than, can we change the design of the implant so that further it will be useful after your study of these 2 types? You told you are doing 2 types of
yes, sir.
Following. Can you, because this was there in my mind for a long time, because we are doing, actually SAR is doing 15 types of joints probably.
Yes,
we should come out with some design which is very useful and better in
so
all
aspects. Yes,
all
sir.
aspects.
Yeah,
If they're possible, just I'm telling as an imaginary question, you can take it.
Sure, sir. I think this was discussed at length when we were in US with the team in Stryker. And they said now, because you have a robot that can put the implant the way we want, you don't have to stick to the natural, the design that we've had till now. They started talking about implants that are circular, that are flat. They started talking about different designs for the lateral side and the medial side. So even if, for example, you can do a lateral uni and a medial uni using the robot and safeguard your ACL and PCL. Even that can be done. So you can't have a more natural feel to the knee than that. So they said they are now, because you have a technology to put the implant where you want, sky is the limit in terms of design. So what will last, what not will last, it's a matter of time. So we have to very carefully take one step at a time. But I'm sure 10 years from now, the implant design will change.
Thank you so much. Good.
Ratnake, you're on mute.
How to decide whether to go for mechanical, kinematic, or functional alignment to your patient? What is your decision criteria?
So that's what I said. The choice is between mechanical and the rest, right? So choice is never between mechanical and alternate. If you want to stick to mechanical alignment, forget about the rest and do mechanical alignment, knowing that your implants will do well and you're changing the anatomy. Whether that has a detrimental effect on satisfaction, probably yes. But once you move out of mechanical and you want to do these alternate alignment strategies, the best any day would be kinematic alignment, right? Because that's the best recreation of native alignment. But then you're putting the implant in such bizarre positions. As a surgeon, you might not accept that. So if you leave the choice to me, I would try to do a restricted kinematic alignment where I can recreate my joint line obliquity and constitutional alignment while leaving my lateral slightly loose and medial slightly tight, so that it mimics a natural knee.
No, but even kinematic alignment, unrestricted,
Yes.
why should it fail? So as if your alignment
Doesn't-
strategies are right, why should it fail when the natural knee is doing well?
So the issue is this, sir. With Stephen Howell's data, they are doing these knees in much less severe arthritis. So the amount of valgus or varus they have to give is very little as compared to our patients. So just imagine if you plan a pure case, sometimes we are even having to give 11 degrees of varus on my tibia, right? So that's too extreme for anybody. So to be in the middle of the pack, that's why restricted kinematic is a good middle path, because you are trying to keep everybody in a HK axis of 3, and we know that definitely works as compared to unrestricted.
Yeah, good. So
there's one more question. Can we have differential poly thickness medial and lateral side instead of the releases?
Those designs are already there. For example, the journey knee, the slope is inbuilt in the actual poly to mimic natural varus. But remember,
even the medial pivot also.
yes. So, but the thing is, it's both, right? It's both alignment and soft tissues. So you have to respect both.
Does lateral alignment work for difficult primary complex cases?
So our stand on this is when you have a very complex case, we try to stay mechanical and do soft tissue releases. We do give some amount of varus valgus. We try to stay within the boundary of 5 degrees of HKA. But right now, that's why we are only doing personalized alignment in CPAC 1 with no bone loss. Bone loss is a totally different aspect. Now we've slowly developed methods to assess bone loss. That's we're studying that to know how much bone loss is there and then how to compensate for it. So if you have a very severe case, stick to fundamental basics and do mechanical alignment for now.
We have completed all the questions, sir.
Okay.
If more questions, then we can move to Dr. Adesh's small presentation.
Just a very quick one. I don't want to take everyone's time. It's already very late. We discussed about, somebody asked how to convert a uni knee to a TKR if required. So I've just put together a quick presentation of one patient. I'm just sharing my screen. So this is not the only way. There are few cases where you're going to have to do some, like put in some augments and, other things, but this is a straightforward one without any fractures or something. This is a case where the arthritis has spread to the lateral compartment. So there's no fracture per se, so you can get away with a regular primary TKR. So it's a 56-year-old lady. She's a doctor from Assam. She had come to us. A uni Oxford was done for her in Chennai 5 years ago. She's been doing well, but later on she was found to have rheumatoid arthritis, and then she started to have lateral aspect pain in the knee. So this is a post-op X-ray 5 years ago. You can see nicely done uni, and if you remember the talk that we had a few weeks ago, a very well done uni with the nice lateral gap is well maintained. But unfortunately, this is how she presented to us. If you can see, that lateral gap has collapsed. So unfortunately, the primary surgeon did not know. She didn't know she had rheumatoid arthritis when she was getting the surgery done, and it was only found later on. So that pannus has probably eaten away the lateral cartilage as well. So after 5 years, she started having lateral knee pain. So first thing is that there is collapse on the lateral side. So it's definitely some lateral wear has occurred. And if you see inside, once we opened up, you can see there's a lot of inflammatory tissue there. The joint itself looks fine. The ACL looks okay, but if you can see, the arthritis is spread all the way to the lateral compartment as well. So first thing we do is take out the poly. If you can, just give a valgus strain. Take out the polyethylene. I hope you can see the videos. So the poly has come out pretty easily because we're able to give a good valgus. And this is what the joint looks like after taking out the poly. You can see that we have that gap over here. Now the first thing is, what are we going to do? You may ask, like, once we take on all the implants, how are we going to get our base for putting the jigs and everything? So what we do first is we take out the tibial base plate. We don't need this there, so we take out the tibial base plate. Comes out pretty fairly easily. Okay, and this is what it looked like after removing the tibia. You can see that's the hole for the keel. And this is a video of how to take the cut. So you put the jig like you normally do with an extra articular jig, and put the 8 mm stylus over there. This is an next-gen Zimmer because the opposite side was also done next-gen Zimmer for her. So here on the normal 8 mm cut, the saw was still hanging in the air. So it was not touching the upper surface of the tibia, the cut surface. So I just took a +2 cut. Take into consideration, I will probably have to take a bigger poly. So I just brought the jig down by a couple of mm by one slot. And you can see now I'm able to get a proper cut. And then we go ahead with that. So you can see now the cut is taking off a small sliver of bone on the medial side. And also your lateral cut is also being taken. And after your tibial cut has been made, this is what it looks like. You have your keel still there from the previous implant. And definitely you've taken a bit of a bigger cut than you would regularly take for a primary TKR. Probably you're going to go for 11 poly then instead of a 9 poly. Okay, so after that,
you kept the femoral implant still in the same place.
Yes, this is what I'm going to show now. So we have treated the tibia. We've taken the tibial cut after taking out the tibial implant. And if you notice, as boss has mentioned, we have not taken out the femoral implant. And this is what we do. We put in our distal jig with the femoral implant in C2, right? Because that's going to act as our femoral condyle. So if you see, this is what it looks like. It's resting nicely on that femoral condyle. And once that's done, we also check with the C-wing to see if we're taking too much of a cut or not. Now, once we have placed this distal cutting jig, then we put in your pins, and then you can take out your femoral implant. Because now it's already in place. You know where your cut is going to be. You take out your femoral implant. And this is what it looks like after removing the femoral implant. Now you take your... Okay, so just as we regularly do, you should be able to take out a bit of a sliver of bone on here as well, on the medial aspect. Of course, you're going to have your peg holes there, but that should not be an issue at all. The next step is now we're going to have to put our sizer and our pins for the 3 degrees external rotation. So what I've done is I've taken a small piece of bone from the distal femoral cut on the lateral compartment, and I have just making sure that it's matching the posterior part of the femoral implant, and you can just place it. Okay, that's where it is. You can just place it there in that the gap over there, and then we can put our sizer on top of that. A small jugaad, this is basically, so that you can keep your guide basically on the posterior condylar axis. After you do that, you put in your 3-degree external rotation pins, and your anterior cuts, posterior cuts, and your anterior posterior chamfers are done. Again, a small sliver of bone will be removed on the medial side. And finally, this is the implantation. You can see I have taken a bit of a bigger poly. I think this is an 11 poly, and I just put in a rod in case, because so there's not too much of pressure on the tibia because they've taken a bigger cut. And it's a nicely aligned, nicely balanced joint. So it's not difficult to do. You can always get away with a conversion of a uni to a TKR if it is required. These are the brief steps. Thank you.
Right. Thank you. And any other questions? So this is the final one, saying the bye-bye.
Yes.
Sir, may I?
Yeah.
Hello. Sir, the journey to knee from Smith and Nephew, also known as anatomical knee, is the result really better than the previous like Genesis, Anthem, or it's the same? मतलब अगर उसका कोई फायदा है जैसे वो advanced है.
So if you look at any implant design, no implant design has proven to be superior over the others.
Okay.
So most implant designs, so the wisdom is to stick to an implant design which is versatile, meaning you should have a CR, CS, PS constraint also, number one. Two, availability. Wherever you're practicing, you should have an implant that has all the sizes. So these two are very crucial. So use any standard ones, which is versatile, which has all design aspects, and then you have availability. Because once you're stuck, if you don't have the constrained implant, or if you cannot convert to a CR to a PS, then you'll end up with more trouble. So more than the design, worry about the availability as well as who's supporting you well. And all standard companies do very well. Don't worry about them.
Okay, sir. Thank you, sir.
Which is easier to convert, UKA to TKA or HTO to TKA? I think both are difficult. You're facing different problems in both. In UKA, you're looking at bone loss. But in a HTO, you've changed the axis, right?
Axis slope.
So your slope is reverse and you're creating valgus. So both are difficult. In terms of technique, I think HTO is more difficult because these knees fail 10 years from the primary surgery, right? UKA fails much earlier if you do a bad job in a year or two. But HTOs come with a lot of contracture, change in the anatomy, patella baha. So a lot of things to consider when you convert a HTO to a TKA.
Literature-wise, H2O to TKR is more difficult and less satisfying results.
Yeah.
Right. Any other questions?
No, sir.
Ashok?
We are done with all the.
Yeah, Ashok.
So only one request from my side.
Mm.
We're currently doing a project perception of technology among arthroplasty surgeons. I think we have at least 70-80 people in this group. I think we'll send out that form to all you guys. It's a request from us. If you can send your the feedback on the questionnaire. We already have 380 responses. We need at least 450 for the study to go through. So if all of you guys can just answer basic questions about technology and its perception, I think it's a good segue because I just discussed about all of them. So you can just fill up. It takes less than 10 minutes for you to do the survey. I think we'll just send it out in the group or individually to you guys. If you guys can give us the responses, it will be great.
Yeah, guys, please do that. Help us.
Yeah, otherwise no certificate.
Yeah, okay. Yeah. So fill that form and then get in touch, come down to the conference, and you will all be as good as anybody in Sunshine in the future. I wish you all the best. And is Ashok or Neeraj there to say official bye-bye? Okay, not yet there. Okay, right. So can we call it a day, faculty? And all the faculty, Sunshine faculty, I'm really indebted to you. You really made a great impact. And as somebody said, your commitment and focus, everybody prepared so well. And it was never a casual approach, wonderful commitment. That shows your zeal to teach. And it's a wonderful way to go ahead. And the best way to learn is teaching. We learn so many things every time. And wonderful. So all the faculty, I owe a great salute to you guys. Thank you so much, all the people. So take care, and probably we'll meet some other fellowship, probably revision TKR or HIPS or something like that. Bye-bye.
First, we should meet at Ishq.
Yeah.
Yes.
Come down, guys. All of you come down. We will ring you personally. Ratnagar,
Yes, sir.
take all the phone numbers. I'll ring them personally.
Sure, sir.
Yeah. Thank you so much.
Tarun,
Thank you,
work on the survey and send it out to these guys.
Yes, sir.
Okay.
Okay.
You.
Any fellow, anybody wants to talk?
I would thank OrthoTV, Ashok Sam sir and Neeraj sir for this great.
Yeah, wonderful, Ashok and Neeraj. It's a
Sir,
great
may-
initiative. You
May
have
we get
really added so much value to the orthopedic learning. Hats off to you guys.
sir? May we get chance for observership?
Ajay Singh, yeah.
Yes. Yes,
Yeah,
sir.
anytime, Ajay, you just get in touch with Ratnagar.
Yes, sir.
So, and we'll be very happy to have you.
Thank you, sir.
Okay. Good. Thank you so much. All the best. Okay.
Bye,
Thank-
guys.
Thank you, sir.
Thank you, sir.